So let's turn to the question of repeat biopsies. And Ross, you and your institution have done some really pioneering work in that in several settings, but particularly with ALK. So what do we get from that? Where, is that something that you think should be done routinely, and how is it going to change management?
So, due credit, the two institutions are Alice's and mine, really, and we both published pretty much simultaneously at the beginning of 2012. So together, I think we felt we had an understanding of why the biology was changing, and we could see that the ALK was changing in a proportion of people. It was getting extra mutations. They were making more of it. And so the cancer cell was just trying to turn the ALK back on in the presence of the crizotinib. And Alice and I, were fairly confident that, therefore, because that was occurring in sort of 30 to 40% of people, that was as good as they were going to get with these second-generation inhibitors. And, usually when you're wrong, it's a bad thing, but this was being wrong in a good way, because actually the benefit from the second-generation inhibitors is much higher. It's 60 to 70%, and maybe even 80 to 90% are actually shrinking. They just don't meet the criteria to sort of get what's called an objective response. So it's a good problem to have, but we don't know what many of those people who have as a mechanism of resistance that still makes them addicted to ALK. So you just come in with a better drug and it works. So there's work going on, but because the response rate is so high, while the repeat biopsies are very interesting from a research perspective, they're absolutely not essential. Because if you've got a 60-70% chance of benefiting from a drug, you don't have to go through a biopsy just to decide if you go on it or not, because you want to go on it.
We should clarify, that's not a cigarette. He's just...
No, I left my cigarettes outside.
Yeah, so that's good. What's your practice with repeat biopsies? Is that something you routinely do or encourage? And then secondly, for both of you, is that something that you routinely, if you do recommend it, is it something that needs a lot of convincing or not?
So convincing, no. Based on prior experience, every time I've had a reason to seek a repeat biopsy, either because of a trial or not, or clinical indication, I've always been surprised about how open-minded to it my patients have been. But in terms of ALK in practice, I don't get repeat biopsies for ALK patients. And it's exactly for the reason that you've stated. I don't have anything I can use it with to help my patient. We've chosen at my institution to open the ARIAD study for our second-line ALK patients. And the activity of that compound against known resistance mutations is actually quite broad. And so since I can't use it, I don't get it.
How about outside of a trial setting?
Well, so the one of the elephants in the rooms is what happens when Plan B stops working. So mechanisms of resistance to second-generation inhibitors, it's all to play for. So I actually think if we're going to invest in research that may benefit ourselves or in the worst case scenario somebody else, then I'm actually pushing to rebiopsy people when the LDK or the ARIAD or whatever stops working, because that's currently totally unknown. And if you're trying to say, well, what is Plan C? Maybe it is going to be a combination, but it should be a rational combination. The second generation plus something that is directed to what's going wrong in those cancers at that point. And that is, we're really at the point now that we were 2 years ago with the crizotinib story.